Everyone, and thank you for Zooming in today. It's really great to have you with us. I am Ruth Katz, co-director of Aspen Ideas Health and executive director of the Health Medicine and Society program here at the Aspen Institute. I'm delighted to welcome you to another Aspen Ideas Health 2020 virtual event. While the COVID pandemic has prevented us from gathering in person, we are delighted to continue to host informative and inspiring conversations with leading health practitioners, advocates, artists, scientists, innovators, and policymakers. And we couldn't be more excited about today's program, a conversation about the urgent need to address health equity in this country. Of course, this is not a new problem, far from it. Indeed, it's been around forever. But the COVID pandemic has demonstrated this injustice so clearly and so undeniably, and in such stark terms and ways that we can no longer turn a blind eye. We are at an inflection point. Hopefully, we will not lose the moment. We've got just the experts, two big thinkers in their fields, to help us understand the health equities exposed through COVID and to explore societal changes necessary to address these inequities permanently. So let me briefly introduce our outstanding speakers now. Dr. Richard Besser is president and CEO of the Robert Wood Johnson Foundation. Previously, he was chief health and medical editor for ABC News. Prior to that, Rich directed CDC's Coordinating Office for Terrorism and Preparedness and Emergency Response and served as CDC acting director during the H1N1 influenza pandemic. A member of the National Academy of Medicine, Rich has won numerous awards, and he continues to practice as a volunteer pediatrician in Trenton, New Jersey. Dr. Besser will be in conversation with Dr. Mary Bassett, director of the Francois Xavier Bagnoud, or FXB, Center for Health and Human Rights at Harvard University. She is also the FXB Professor of the Practice of Health and Human Rights at the Harvard T.H. Chan School of Public Health. Mary has over 30 years of experience in public health and advancing health equity, most recently as New York City's Health Commissioner from 2014 to 2018. Also a recipient of numerous awards, Mary has directed programs at both the Doris Duke Charitable Foundation and the Rockefeller Foundation. With that, Dr. Besser, Dr. Bassett, thank you again for taking time from your incredibly busy schedules to join us for undoubtedly what promises to be a really very interesting, terrific, and important conversation. And of course, our thanks to all of you in our audience for being with us. We look forward to seeing you soon for our next Aspen Ideas Health event. Mary, let's get the conversation started. Thank you both again.
Thanks very much, Ruth, for that framing and those great introductions. And Rich, it's really wonderful to be in conversation with you. We've had quite an eventful past few days. We had a presidential election. We have a new COVID-19 task force. We have news of a very promising vaccine from Pfizer. And as a nation, we've hit 10 million in documented infections. The actual number is certainly higher, and we're well on our way to hitting 250,000 deaths by Thanksgiving. So the virus carries on, but it hasn't been affecting all populations in the same way. And it's clear, and it has been clear for months, that there are populations that are harder hit, as Ruth referred to. This pandemic has displayed the fissures in our society, and Blacks, Latinos, Indigenous people, American Indians have been hit the hardest. Now, there are a lot of ways that people explain this, and I wonder how you've been thinking about it. We have rates that are 3.5 times higher for African Americans, well over twice as high and rising for Latinos, devastating rates in indigenous populations.
Yeah, Well, first, Mary, it's always a privilege and a joy to get some time to have a conversation with you, and so I thank you, and I thank Aspen for making space for this. You know, there are a number of narratives that are out there as to why this pandemic is not hitting all communities, all populations in the same way. Clearly, everyone across America is impacted by this, but those numbers you lift up, you know, I think early on came as a surprise to some, but I think to those who work in public health, those who work in the areas around racial justice, there's no surprise here at all. With this pandemic, I think there are a number of factors, and I know you've looked at this in an important way. The biggest one being differences in exposure. You know, I'm sitting here in my basement, easily able to work. We closed our foundation in March. We're able to do our work. We've got the technology and the ability to do that. For millions and millions of people in America, if you don't work, you don't put food on the table, you don't pay rent. If you look at what are considered essential jobs in America, whether it's frontline healthcare workers or first responders or people in food production and transportation, you see a much higher proportion of people of color in those occupations. And early on in this pandemic in particular, while there's a lot of focus around personal protective equipment for people in healthcare, there sure wasn't for people in my grocery store, or for people driving the bus, or for people who were in jobs around food production. And so that's a critical piece of that. You can leave the narrative at that level, or the analysis, but I think if we're really going to talk about solutions, we have to move upstream and say, well, why is it that Blacks, Latinos, Native Americans are disproportionately in jobs that don't pay a living wage, that pay much lower, and it takes you to conversations around structural racism. And I think that if as a nation we want the next pandemic to play out differently, and the period after the pandemic to play out differently, we have to be wrestling at this time with the issues that are out there around the racial justice movement. You know, you did a study looking at this, right?
Yes. Yeah. Well, we took a look at not just the aggregate mortality rates, but the age-specific mortality rates, because these average measures really can be misleading. If we didn't look at it by race, and as you know, for some months we were unable to look at national data by race, we would not have seen those differences. And it was the cities and states that sounded the alarm early on, very early on in March, early April. But what we found is when you look at specific age groups, that particularly Blacks and Latinos had far higher rate ratios. That means if you put, as compared to whites, if you compared the mortality rate and made a ratio against whites. So for Blacks between 35 and 44, 9-fold higher. That's the same as saying 900%. And for Latinos, 7-fold higher. So these are differences that we can't explain only by behavior, which is frequently trotted out. People aren't following advice or haven't heard it. Or by comorbidities, which is another explanation that's often, although that's true and also socially determined. I think something that I know you believe, so I'll just be repeating what you said, but when we talk about structural racism, we're really making clear that it's not your race as it's been assigned in the society per se. It's not something inherent in being
Right.
Black or Latino. It's what it means in our society, where you live, how many people live with you, where you get to go to school and how likely you are to finish, what kind of chances you have in the labor market, what your ability is to navigate healthcare. And actually, now that we're saying it, we have We have that before the Affordable Care Act before the Supreme Court. So if you think about any one of those steps, there are structural reasons that have nothing to do with direct personal choice that disadvantage people of color. And you're exactly right. That's what we have to change. That is what we hope will be the silver lining of all this suffering and death, is that we'll realize that we, can't just yell at people and say, wash your hands. If, as in the Navajo Nation, 30% of households had no running water. People need advice that they can use. And,
I think that when I reflect back to my years at CDC, we spent so much time developing recommendations and much less time talking about who has the ability to follow those recommendations. And I've seen that play out here in this pandemic early on, in particular, when you looked at the guidelines from CDC around what to do if you thought you had COVID. It was, call your doctor. Don't go to the hospital because you could be exposed or put pressure or expose healthcare workers. Well, 28 million people at the start of this didn't have a doctor to call, uninsured in our current system. And then if you needed to go test it and get tested, there were a lot of states that only set up drive-through testing facilities. So if you didn't have a car, what were you supposed to do there in terms of engagement? And I think that there's a reckoning that has to take place within public health to see what changes need to be made to ensure that the right information is being collected, that the recommendations are addressing the needs of all. And there's been improvement over the course of this in terms of developing that. But I remember talking with you when you were in New York City about the importance of data and data collection. And I was wondering, if you could just say a little something about that, because you were able to detect things within New York City using data that were really profound.
Well, New York City is really unusual as an urban jurisdiction. It controls its own vital registration. So if you look at the reports from the CDC and the MMWR, Mortality and Morbidity Review, you will see New York City down there at the bottom. So New York, the health department was able to collect also survey data. And we increased the size of that sample when I was commissioner so that we could make estimates down to pretty granular levels and say things about neighborhoods. And in a city like New York, when you're talking about neighborhoods, because it's such a segregated city, and you're also talking about population groups. And so New York City actually was the first jurisdiction that I saw that put out age-adjusted mortality rates. We used rates and age-adjusted them. And that was the first signal that something was going on with age, because it shifted so much for the white population, because that population was dying principally at elderly ages, over the age of 80. So that's why we undertook this study to use the national data and see age-specific mortality rates by race. And it only became possible to do in May because the federal government just wasn't making race data available. It's on the death certificates. They still aren't making education attainment on the death certificate available. Occupation is on the death certificate. Now they'll say that the data aren't good enough, but if we don't use it, it will never improve. And they mandated it by August 1st, and it's still on average, half of the race data are incomplete. So data are really important. They allow us to see which populations are hurting, and that's how we can direct our interventions and see where we need to focus our resources and what the problems are. I think that's why, for me, the data on exposure being related to being out and about are really important, because this should be driving also our interventions. So I wonder what you think about that. You know, everybody talks about access to testing. That's good. We need that. Masks, that's good. But what about, you know, paid sick leave? So that low wage workers, most of whom lack paid sick leave, you know, don't go to work sick because they need to keep, you know, feeding their families and paying their rent.
Yeah, I see it playing out in a number of ways. You know, clearly, I think your analysis in terms of exposure being the big factor is critical. And right now, when we're seeing so much pandemic fatigue across the nation and people just getting tired of being locked in, tired of wearing masks and washing their hands and social distancing, well, for many people, you know, doing those things is an inconvenience. For people who are in the workforce, people not doing those things puts them at risk of getting a potentially fatal illness. And so it's, you know, as we have these national conversations about individual responsibility and people's rights to not do something like wear a mask or social distance, those decisions are clearly putting other people at risk and disproportionately putting at risk people of color. And when you get to the policy side that you were just raising, you know, fewer than half of workers who are in lower paid jobs have sick leave, have family medical leave, have unemployment insurance. You know, people who are putting it together by working, you know, 2 or more minimum wage jobs don't have unemployment insurance. So, you know, the idea that people in communities are not doing these simple things of wearing masks and socially distancing, they are harming those people who have no choice but to work. And your point about what then happens, you know, if there's a greater proportion of people of color who live in multi-generational households, they're not only exposing themselves and maybe their own risk is lower, they're bringing COVID home. You know, so, you know, we've put forward, you know, the policies we think are critically important, and one of them would be that we have universal sick leave and medical leave. Another is that we raise the minimum wage so that everyone is paid a living wage. And yeah. It's
right. I mean, this doesn't seem like it should be perceived as that radical.
Yeah.
All of our sort of peer nations offer, you know, other wealthy countries, you know, rely on paid sick leave, on family leave, so they can take care of someone in the household who's sick or be home with a new baby, and also, you know, have access to health insurance. So, you know, we're unusual as a nation. I think
when we were having our prep call a week ago, it feels like years ago because so much has changed in a week. But now we have clearly a new administration coming into the White House. Unclear whether there's going to be a split within Congress between parties. You know, something like universal health care, which look like it might be able to move forward, is, you know, who knows how that's going to be able to play out. But one of the things that's different this week than last week is that there's now a strong signal that there could be a very highly effective vaccine coming down the road, and that's really exciting. But it raises the question, you know, a couple equity questions, but one that I want to get your perspective on is, you know, if we have a vaccine that's highly effective, and people don't want to receive it, we're not going to turn this around. And the experience of communities of color over history with public health and medical research has been grim. So how do you think about addressing those issues of trust so that if there's an effective vaccine and it can be distributed in an equitable fashion, people are going to want to get it?
Right. So there are a lot of steps before it gets to whether the person decides that this is a complicated vaccine and has a demanding cold chain. You have to keep it frozen at minus 70 degrees Celsius and so on. But okay, and you have to make enough of it. And of course, we have to see the final data to see if this wonderful number of 90% efficacy holds up and who was benefited. We haven't seen the data. But that said, I mean, when I was the health commissioner in New York, one point that I always made is that people have good reason, as you've just outlined, to have distrust in public health authorities. So we should not attribute that to, people just being defiant or people, just being obstreperous. This is based on history. And we in the public health field have something to answer for, as does medicine as a whole.
Yeah.
Which, so we got to acknowledge that. And it's just the usual slog. Every barrier that we can reduce, we have to. It has to be affordable, has to be available, and has to be, available in places that are convenient to people, and all that. And then, we have to do the hard work of getting community leaders and trusted figures to, join with us, show the way. I think that it won't be easy. I mean, we have the flu vaccine, a very safe vaccine. It's been given around the world, probably to billions of people. And yet we have only 50% uptake annually about in the US, and then for the African American community in particular, it's lower than that. I guess it's higher than that. It's about I'm not sure the actual numbers. It's 50, 60%, something like that. So, we're going to have our work cut out for us. I'm excited about this vaccine. So I don't want to sound like, this is the one who always thinks of, oh, that sounds great, but here are all the difficulties, but there really are difficulties. Nobody has, there's no -70 freezer, in any doctor's office in the neighborhood where I'm living now.
Yeah.
So there are going to be a lot of other difficulties, but it's very exciting. And
I think we've got some questions there. Maybe I think Ruth is going to rejoin us here.
Thank you.
We do indeed. We've got them stacked up. So let me jump right in. I hate to interrupt this conversation, and it's been terrific. But you both mentioned there's a lot of news this week. A lot's changed in the last week since we did our prep call. And one of the things that has changed is the establishment by President-elect Biden of a new COVID-19 advisory board. What would you guys expect the board to do, or the advisory board to do over the next couple of months? What would you hope to see come out of the board, especially given that several of its members are considered to be real health equity experts and champions? What would you hope to see come out of the board?
We're talking about the COVID-19 task force, the one that has been announced by President-elect Biden.
Yep.
I hope that they get beyond, we need more tests, which we do. And we need more, need to assure PPE, which we do. And also begin to talk directly about some of the things that Rich and I have been discussing, that we need to rebuild trust that has been squandered, frankly, in the initial response to COVID-19. And we need to draw on not just a group of technical experts, but also on people who know about those things and know history, and who are, advocates for equity in a more general sense, not only with respect to health. So the task force has a real talent. They're really smart people. They have a really big job ahead of them, including potentially vaccine distribution issues. But gosh, we have one. I mean, we have not had a national response. I don't know. How are you feeling about it, Rich?
Yeah, I think I'm as optimistic now as at any point during this, and a part of that is just the general framing that this will be led by the best public health science available, that there will be transparency, that politics will follow public health instead of public health being told to change their recommendations to suit politics.
Yeah.
That's huge, and if you'd asked me 2 years ago whether we would ever have a response that wasn't led by the best public health science, I would say no. Just thinking of all of the, I led emergency preparedness and response at CDC for 4 years, and then at the start of the Obama administration, and both, the Bush years and the Obama years, it was always driven by science.
Right.
So getting back to that will be critical. And I really see their role being this bridge during this period, so that following inauguration, CDC, FDA, NIH can be back in their roles of leading this and driving this, and being supported by politics. I was thrilled to see that one of the co-chairs of this, her area of work is around equity.
Yes.
And to hear the vice president-elect talking about the importance of equity not being something on the side, but being central to how you think about this response.
Right.
That's all. To me, that's huge. But the challenge is we've got 70 plus days of this administration leading this. It's the winter. The numbers are going up around the country, and I hope that governors now of both red and blue states, step up. Mandate masks, look to see what they can do within their own states, recognizing that the federal response, a unified federal response, is still several months away. There are tens of thousands of lives that could be saved if states drive this forward and do the right thing.
And yeah. All right, you have another question.
I got them stacked up here, so I'm trying to get one more in. This is terrific.
Yes.
I think now about health equity a little more broadly. The question is, what are some strategies that health professionals can use to hold their organizations accountable for their contributions to inequity of that people of color experience? What can health professionals do about that?
Wow.
Yeah.
This is an accountability.
No, I'm just thinking,
I hold people accountable.
I hate to be too nerdy because this is about human beings. And I was just thinking, as Rich was speaking, that, that the task force has working against it, these trends that we're seeing. And we don't want people to say the rates are even going up even as we speak, and look at what attribute that to the task force. That reflects past failures, not current efforts. But so I don't want to be too nerdy, but we need data. People need to be able to look at their data and see how their organizations are doing. For example, there was a study done in LA. I don't even know the researchers, that showed that most African Americans were being tested positive for COVID at a hospital. So that suggested that they were getting tested when they showed up sick, and were being diagnosed late. And then it's a job of health professionals to say, why aren't we finding the people sooner? How can we make it more possible for people to come to our hospitals sooner? So part of it is, knowing your organization and its own practice. And that's the responsibility of every practicing physician.
Yeah, and just to add on to that, I think going forward, when we're thinking beyond the COVID context, again, it comes down to data and making sure that your health system is collecting the kind of data that are necessary to see whether you're having disparate disparities within your system by race, by ethnicity, by zip code. The ability of New York to do that and drill down to that level is incredible. But if we're thinking about an equitable response and recovery from this pandemic, every state has to mandate and has to ensure that data are being collected down to the neighborhood level, where you can disaggregate by race and ethnicity. Or as the recovery goes forward, what the big fear is, and it's going to be no surprise, you're going to be seeing wealthier white communities bounce back, and communities of color left behind.
Yeah. Let me, because I promise not to keep you longer, but if I could just throw in one more question, even though I've got dozens sitting here. Can both of you comment of the impact of the pandemic on the homeless population?
Well, the homeless population is particularly disadvantaged. We had some confusing data from Healthcare for the Homeless in Boston. They found incredibly high rates of COVID-19 when they tested people who were resident in a shelter. So, there are two types of homeless people. There are people who are living on the streets, and there are people who are living in shelters. And so the shelters have all the risks of congregate housing and congregate eating, and just as we see in detention centers and prisons and jails. Anyway, they found really high rates. 40% of tested positive for COVID-19, and hardly anyone was sick. I still don't know really what to make of that, but this is clearly a disadvantaged population, which it has very little access to healthcare in general, and is one that in congregate settings is at special risk. So you have to make testing and quarantine and isolation. You have to put it into practice.
And I want to come at that from just a slightly different angle. And I think that we are at major risk of the homeless population expanding by tens of millions. Back in March, with the CARES Act, where Congress put in a moratorium on evictions and mortgage foreclosures, that expired, and CDC was then put in the position of putting a ban on evictions for public health purposes. That expires in January, and the estimates are that there are tens of millions of people who will become homeless if Congress doesn't step up and not only put in a moratorium on evictions and mortgage foreclosures, but do rent forgiveness and mortgage forgiveness.
Thank you.
Because without that, there's absolutely no way to dig out of the hole if you look at the wealth gaps in America. And this is something that is is absolutely shameful, that we would allow people to lose their homes at a time of a public health crisis, a pandemic, where being able to have a safe place to be is so critical for disease transmission.
Yeah, no, thanks for pointing that out. That's
I'm just going to hang in for one last question, which is really, I'm consolidating a bunch of questions. Now that we've got people's attention on this issue of health inequities, including policymakers, what would each of you suggest are the top 2 or 3 things we could do relatively immediately to address health equity in this country? And I'm going to make it a little tougher, other than expanding Medicaid. Other than Medicaid, for all 4, what would be 2 or 3 things that each of you think we could do relatively quickly that could make a real impact on this question, on this problem? Rich, I'll let you go first.
Well, it's what we should do rather than what I think is politically feasible right now.
Okay.
I think what we should do, and may be feasible for the short term, is putting money back in people's pockets. Direct payments, that was shown to stimulate the economy, to forestall evictions and foreclosures. Putting money into lower income individuals' pockets it would be critically important. I can't say Medicaid expansion, or I would say Medicaid expansion. Supplements, provide supplements again to the unemployment. A lot of the stuff that was in the CARES Act, redo that, provide resources to businesses, small businesses, so that they can survive, because those that rely on outdoor activity are going to be in big trouble now that the weather's cold. But then longer term, universal health care is critically important. Living wage is critically important. Eviction protection, mortgage foreclosure protection is important. Sick leave, medical leave, these are all critical pieces.
Mary?
I'm glad I got to go first.
Well, just to say that all of these risks, I read somewhere that 40% of Black-owned small businesses have gone under. So everything that Rich has talked about is amplified in terms of consequence across the racial, ethnic divides. But he foretold that we wouldn't disagree on much, and I agree with him on all of these. This is a very rich country, and this is the time to open the coffers and help people get through this. It will cost much more to build back than to enable people to withstand this, and it will help us end this pandemic, because the two of them shouldn't be seen as, you know, on the one hand, we can end the pandemic, on the other hand, we can save the economy. The way we save the economy is by bringing this virus under control.
Well, and Mary, your comment about the failure of black businesses is absolutely heartbreaking if you put it next to the fact that that's the most rapidly growing sector in entrepreneurship, is growth of businesses by Black entrepreneurs.
Yeah.
You know, it's important to have that asset frame, that this is what the future and vibrancy of communities in America, if you allow for businesses to move forward. You know, and we saw with the CARES Act and the payroll protection plan that banks were not loaning to Black businesses. It was another example of structural racism. If we're
banking, you know, relationships.
Exactly, who has the relationships, and it was set up so that, you know, clearly a bank would give to their customers first. Right. So if we allow these businesses to fail, what does it say about the American dream and opportunity and the, you know, what we consider to be these values in our country?
Yeah. As I said, we're at an inflection point, and we've brought you folks out in the audience, two of the best, two of the big thinkers, as I said. Thank you, Rich. Thank you, Mary. We kept you a little longer, and I can't tell you how many questions we never got to. So thanks for a great discussion, and thanks again to our audience. We'll see you again soon. Take care. Get your flu shot.
Yeah.